Hello, and welcome to my presentation about therapeutic hypothermia. Today we are going to discuss therapeutic hypothermia. A quick synopsis of what therapeutic hypothermia is and why it is used is where we will start. Therapeutic hypothermia is where a patient's body temperature is medically reduced through two different ways or means, either through surface cooling or endovascular cooling. Surface cooling is exactly what it sounds like. The patient is covered with a cooling blanket, ice packs, cooling pads, and other means to reduce the bodily temperature of the patient to be between 32 and 34 centigrade. Endovascular cooling is a rapid cooling technique. With this technique, a balloon catheter is inserted into a central vein, and with a closed-loop internal cooling circuit, the catheter cools the patient's blood as it circulates past the catheter and continues to circulate through the system. The two indications for why therapeutic hypothermia is used are as follows. 1. Post-cardiac arrest, typically in adults, and 2. For neonatal asphyxia. After cardiac arrest has happened and the patient's heart has been restarted through CPR or other means, healthcare providers will use cooling devices to lower a patient's body temperature for a short period of time. The patient is also typically sedated to prevent them from shivering, which is one of the body's attempted ways to warm up the body through movement. For those recovering from post-cardiac arrest, if the patient wakes up after their heart restarts, this technique is not used. This technique is only used on a patient when their heart has been restarted, but the patient is still unresponsive. Therapeutic hypothermia should be initiated as soon as possible after ROSC, return of spontaneous circulation, and is used as a way to decrease the post-cardiac arrest syndrome inflammatory cascade. Don't worry too much about this slide. I know there's a lot of information on it, but you don't need to understand it in order to understand what is going on. This inflammatory pathway, or cascade, is activated due to the ischemia and subsequent reperfusion in the body. The glial cells found in the brain respond to ischemia and reperfusion by activating the inflammatory response, which in turn results in an inflammatory cascade, which continues to activate the responses of other cells found in the brain, such as microglia, the blue blob found on the right, and astrocytes, the yellow blob found on the left. You can see the microglia responding to the peripheral inflammatory response coming from the blood-brain barrier in the top right, and between the astrocyte and microglia you can see a positive feedback loop of inflammatory responses, along with the other cells below that they are both communicating with. This cascade results in an ever more enhanced inflammatory response, which can become devastating to the brain. This inflammatory response continues to invite peripheral immune and inflammatory cells into the brain, causing swelling, edema, and ultimately disrupts the blood-brain barrier. These course of events will eventually lead to cellular brain death. In the article, Therapeutic Hypothermia After Cardiac Arrest, Benjamin Skorica states that hypothermia aborts activated programmed cell death pathways by reducing the release of excitatory amino acids and free radicals, and by minimizing the intracellular consequences of excitotoxin exposure. You can see in the bottom right corner, that's what he's talking about. As they release those factors, it incites cell death. In addition to these effects of hypothermia, it also decreases the cerebral metabolic rate of oxygen consumption, cerebral blood volume, and intracranial pressure, thereby decreasing the supply and demand of the cells within the brain, thus preserving the brain cells until oxygen supply can be reestablished. As per the technique of therapeutic hypothermia, the patient's hemodynamics will need to be monitored. During the initial stages of cooling, the patient will show signs of tachycardia and hypertension as the patient shivers in an attempt to conserve heat. But once the patient begins to cool, bradycardia is the most common arrhythmia, along with PR complex and QT interval prolongation to complement the sinus bradycardia. The second use for therapeutic hypothermia is for neonatal asphyxia, for much of, if not the exact same reasons above. There are numerous ways and reasons that a child forming in the womb can have complications during development, which can result in hypoxic or ischemic events that can, and often will, lead to brain damage because of the above listed reasons unless they are caught early. The exception for neonates is that there are so many more factors that could go wrong during development in the womb that can lead to a hypoxic and or anoxic event than typically does for a grown adult. And unlike adults, a premature infant is extremely less resilient than a fully grown human being, and it is very difficult for them to adapt to any new environment quickly, especially if they are premature. As with every procedure performed in the medical setting, there are risks involved. This list is just a few of them to look for. 1. Abnormal heart rhythm, and especially low heart rates during procedure. 2. Severe infection or sepsis. 3. Blood is less able to clot, which can cause hemorrhaging. 4. Electrolyte and metabolic problems. 5. Raised blood sugar levels or hyperglycemia. During therapeutic hypothermia, lower temperatures decrease insulin secretion and increase insulin resistance. The overall purpose of therapeutic hypothermia is to preserve brain function post-cardiac arrest. To recap and sum up each way that this happens will be listed as follows. Therapeutic hypothermia preserves brain function by 1. Reducing cerebral metabolism, leading to less oxygen and glucose consumption. 2. Because of the reduced oxygen and glucose consumption, free radical formation is decreased, primarily oxygen-free radicals. 3. Promotion of cerebral vasoconstriction, which directly can reduce intracranial pressure. Vasoconstriction also decreases membrane permeability and therefore reduces the amount of edema that can form. 4. Prevention of neuronal injury leading to programmed cell apoptosis or death by inhibiting the caspase activation chain. 5. Suppression of the inflammatory cascade and decreased nitric oxide, cytokine, and leukotriene production. And 6. Improved ionic homeostasis and blocking of the destructive neuroexcitotoxic cascade, consequent to glutamate accumulation and receptor activation, and subsequent intracellular calcium overload. In the end, therapeutic hypothermia, when used correctly and timely post-cardiac arrest, can be a brain and life-saving technique. Thank you for listening to my presentation. Here are the references.